That is diabetes in pregnancy, and it is of two types: overt diabetes and gestational diabetes. Now let's first come to the overt diabetes, and this is a female who already has diabetes when she has conceived, and her blood sugar levels, they are increased right from day 1 of the pregnancy. So subsequently free radicals, it will be formed right from day 1, and so there will be increased chances of congenital malformations in this overt diabetes group. Now coming to the other group, that is the gestational diabetes, and in this the females are normoglycemic when they conceive, but the blood sugar levels, they start increasing after 24 to 28 weeks, because this is the time when there is maximum insulin resistance. So subsequently free radicals, they will be formed after 24 to 28 weeks. And since by this time the organogenesis is already complete, and so in this group the chances of congenital defects, they are minimal, that is similar to a normal population. Now we will discuss overt diabetes in detail, and a pregnant female is said to have overt diabetes if her fasting blood sugar levels, they are more than 126 mg per dl, or the random blood sugar levels, they are more than 200 mg per dl, or the HbA1c value, it is more than 6.5%, or the 1 hour screening test, that is the GCT that we do with the 50 gram glucose, if the blood sugar levels in that is more than 200 mg per dl, then we categorize the female as having overt diabetes. Now as we said that these females with overt diabetes, they have hyperglycemia right from day 1 of the pregnancy, that is the day they have conceived, and so the free radicals formation, it is also increased right from beginning of the pregnancy, and this is the reason during organogenesis the fetus is exposed to this free radicals. So there are increased chances of congenital malformations. And the test which predicts the congenital malformation risk in these overt diabetic females is HbA1c, again one important question. So let us now see the risk of congenital malformations at different values of this HbA1c. If the values are less than 6.5%, she does not have any increased risk of congenital malformation. If this value of HbA1c is between 6.5 to 9.5%, the chances of congenital malformation is 5%, and at the levels more than 9.5%, the risk of this congenital malformation, it increases to 20%, a very high risk. Now, how do we diagnose these congenital malformations? As we have already discussed, the TIFA scan, that is targeted imaging for fetal anomalies, or level 2 scan or anomaly scan, that we do at 18 to 20 weeks of gestation routinely, it is the best test to diagnose the congenital malformations. Now, if a diabetic female comes to us in the periconceptional period, then what are the measures that we can advise her to decrease the risk of congenital malformations in the fetus? The first is strict glucose control, and the next important is the folic acid supplementation, 400 micrograms per day. These two measures can reduce the risk of congenital malformations in the diabetic mothers. And once these patients conceive, so the drug of choice in them is insulin. The oral hypoglycemic agents that we can use in gestational diabetes, they are contraindicated in overt diabetes. And so the pregnant females with overt diabetes, they have to be always treated with insulin. Now coming to a few one-liners in relation to the congenital malformations in diabetes, the most common system involved in congenital malformations. So if the question asks about the most common system involved, your answer will be cardiovascular system, that is involved more than the CNS. So the second system to be involved is CNS. Now if your question asks the most common congenital anomaly seen in relation to diabetes, then it is VSD, which is seen more than neural tube defects. So if VSD is not there in the option, then your second most common congenital defect is neural tube defects. Now if the question asks the most specific anomaly in relation to diabetes, then it is caudal regression syndrome or sacral agenesis, as you can see in this image. And what do we mean when we say specific anomaly? We mean that if a baby has caudal regression syndrome or sacral agenesis, then the mother is definitely having diabetes. Then if your question asks most specific cardiac anomalies seen in cases of diabetes, then your answer is transposition of great arteries. Again, this transposition of great arteries, it is specific to diabetes. If it is present, then the mother definitely has diabetes. Now, instead of specific, if your question is most common cardiac anomaly seen in babies of diabetic mother, then it is VSD. Now, there is one another question which you need to differentiate by every word. The most common CVS finding seen in the babies of diabetic mother, and the answer is HOCM. And the least common cardiac anomaly seen is tetralogy of Fallot. So these are the best examples where you can see where a single word changes the question completely. So be very careful about the words of the question. Now coming to the risk factors for gestational diabetes and their categorization into low risk, average risk and high risk. Now first coming to the low risk group, and in this we have the females with age less than 25 years with a normal BMI before pregnancy, and if she had previous pregnancies then the babies were of normal weight. There is no family history of diabetes, no history of poor obstetrical outcome and no history of abnormal glucose metabolism in the past. So these females are categorized as low risk. Now coming to the average risk females, and those with the age more than 25 years, those who were overweight before pregnancy, with history of diabetes in first degree relatives and previous babies with increased weight at birth. So they come under the average risk group. And now coming to the most important, that is the high risk group, and in this we have females with age more than 30 years with marked obesity, with a previous history of GDM, that is GDM in the previous pregnancy, and with a strong family history of type 2 diabetes mellitus, and if she had congenital malformations in previous pregnancies or history of 3 or more spontaneous abortions or a stillbirth or a IUD in previous pregnancies, that is a group with bad obstetrical history. Then if she had polyhydramnios or macrosomia in previous pregnancies, and these factors if present, they bring her into the high risk group. Now there is one more thing that we missed out. If the female belongs to an ethnic group with low prevalence of GDM, then it comes under low risk, and if she belongs to a group with a high prevalence of GDM, then she belongs to an average risk. So this was an overview about diabetes in pregnancy, and further we'll continue with the diagnosis of diabetes in pregnancy. Thank you.